Just a brief intro to who we are. We are the IPRO QIN-QIO. We're a federally funded Medicare Quality Innovation Network and Quality Improvement Organization. We have contract with the Centers for Medicare and Medicaid. We are one of 12 regional offices nationally. And as you can see below, we are 3 organizations under one arm. IPRO, Health-Centric Advisors in Clarent, and the states that we cover are listed below. And our aim is to work to ensure high quality, safe healthcare for Medicare beneficiaries. Next slide. So I am excited to present our 2 presenters today, Laura Benzel and Laura Vanderhill. Laura Benzel is a project director and a health equity lead for Clarent. Laura Vanderhill is a licensed social worker who's a quality improvement specialist working for Health-Centric Advisors in the Communities of Care Division. Very excited to have these ladies present a great presentation. So Laura Benzel, take it away.
Great, thanks, Mariella. It's great to be here today. I'm going to be talking about specifically disparities in US vaccination rates today. And we know that vaccinations can significantly decrease deaths from vaccine preventable diseases, but we know that there are certain populations in the US that are less likely to get vaccinated for these diseases, which of course is an issue. So there are a variety of factors that contribute to disparities in vaccination rates. And what I mean by disparity is that there are some groups of individuals who have lower vaccination rates compared to a reference group. So for example, certain racial and ethnic minorities have lower vaccination rates for some vaccines compared to white individuals, which are the reference group. There are also disparities based on age, where a person lives, socioeconomic status, and certain vulnerable populations, such as those in the LGBTQ+ community and individuals with disabilities, also experience disparities. So there are a variety of reasons for these disparities. There is limited or no access to consistent health care for some of these individuals. They may lack health insurance. Many individuals don't have sick leave, so they're not able to leave their jobs to go to medical appointments or to get a vaccine, which is a major problem. There is also limited or no access to minority health professionals, and this includes both doctors and pharmacists. And so that lack of parity sometimes causes distrust. If you're a minority, you may have distrust in the healthcare system because of that lack of parity. You're more likely to trust someone with the same race or ethnicity. This can also cause avoidance in seeking healthcare. And this is particularly true for the LGBTQ+ community because they face discrimination and lack of affirming care. So the tendency is for them to avoid healthcare, to avoid that pain that they experience when they experience discrimination. We also know that limited English proficient individuals may have communication issues, and that can lead to misinformation, low health literacy about why to get vaccinated. And, there are unreliable resources, as we know, or unreliable sources out there, such as social media, that is spreading misinformation about vaccines. And so all of those contribute to these disparities, but a big one is social determinants of health. And my colleague Laura will be discussing those more a little bit later in the presentation. So we know that COVID-19 brought to the forefront longstanding inequities that have systematically undermined the health and the quality of life for racial and ethnic minority populations. They are bearing a disproportionate burden of COVID-19. So these data from the CDC show COVID cases, hospitalizations, and death for 4 racial and ethnic minority groups, and this is compared to their white counterparts. And you can see that all 4 minority groups have experienced worse health outcomes because of COVID-19. So for example, if you look at the column for American Indian or Alaska Native individuals, we see that they have experienced death due to COVID-19 at more than 2 times the rate of their white individuals. So we're seeing these disparities across all 4 of these racial and ethnic minority groups. Another example of a difference in COVID vaccination rate is due to geography. So when we're comparing urban and rural geographic locations, we can see from this map that rural areas tend to have lower vaccination rates, and they are highlighted with the lighter blue shading. The latest data show that Wyoming, Alabama, and Mississippi have the lowest COVID vaccination rates currently at about 52%. That's based on data from about a week ago. A shout out to Rhode Island. Conversely, they have the highest COVID vaccination rate for their residents at about 87%. And just as a side note, according to the CDC, as of December 7th, over 80% of people in the United States have received their first COVID-19 vaccine dose. And about 69% were considered fully vaccinated. And what we mean by fully vaccinated is that individuals have received 2 doses of either the Pfizer or Moderna vaccines, or they received 1 dose of the Johnson & Johnson vaccine. So that's how the CDC defines fully vaccinated. So the good news, as you can see from this chart, is that we've seen the gap in COVID-19 vaccination rate closing among racial and ethnic minorities. So these data from December 14th through January 4th, we see that the rate of receiving at least 1 dose or having completed the primary series is higher for all the minority groups except for Black individuals. And this is compared to white individuals. But if I could bring your attention to the last column or the last row at the bottom, highlighted there in red, we can see that certain minority groups are lagging in getting the bivalent booster. But really, if we look at all of the data there, we see that in fact, there's work to be done to increase the bivalent booster across all of the groups that are shown here. So we see similar disparities in influenza vaccination coverage. Hispanic, American Indian, and Native Alaskan and Black adults received influenza vaccine at lower rates compared to white adults. And these data are for the 2021 through 2022 influenza season. And the reasons are very similar to those I discussed earlier: lack of access to healthcare, lack of insurance, no medical leave, misinformation, mistrust, and low health literacy. Historically, persons from some racial and ethnic minority groups have had higher rates of influenza hospitalization and death, and lower influenza vaccination covers that I just discussed. And again, this is compared to white individuals. So racial and ethnic disparities were consistently observed among Black and American Indian, Alaska Native individuals and Hispanic individuals compared with white adults. Their hospitalization rate was an average of 1.2 to 1.8 times those in white individuals. And this is for the 13 seasons that you see here on this graph. So I'm now going to turn this over to my colleague, Laura Vanderhoe, who's going to talk about social determinants and how they contribute to vaccine disparities.
Thank you so much, Laura. That was a really good introduction and overview of some of the disparities that we're seeing. So just to build on what Laura was saying, as I'm sure you all know, social determinants of health are defined by Healthy People 2030 as conditions in which people are born, live, learn, work, play, and age that affect your health, functioning, and quality of life. And you can see the different categories that are listed here. Next slide, please. So this is just a more detailed breakdown. So you can see, a lot of what, we've already touched on is listed here. So, you can see, vaccine access and also access to the right information about vaccine, because certainly you can see how, it would come up under different areas. So for example, if you are unemployed, you may not be able to afford, you may not have health coverage, you may not have internet access. So that sort of, comes under, maybe your housing status, if you're marginally housed. Transportation, of course, is a huge factor in terms of accessing vaccines. And, as Laura already touched on, literacy and language. And then what I find interesting, looking under the community and social context, is I really think that, social isolation comes under that. And, problems related to living alone is one of the top, Z codes identified, and Z codes are under the ICD-10 codes. It's a way of, labeling, social needs that, come up through social determinants of health screening. And I think, if you don't have the social and community supports, that can also have an impact on, your access to vaccine information and the vaccines themselves. And then, of course, there's, actual, healthcare access and looking at the cultural and linguistic components. Next slide, please. So we all know that social determinants of health are important. They really account for, together with health behaviors, about 80% of your health. So much of health happens outside of healthcare. And, putting all this together, can really lead to a significant gap in life expectancy. Next slide, please. And this is just looking at, the same information, but more through a financial lens. As we all know, getting vaccinated is a huge part of reducing avoidable, hospital utilization and other expensive healthcare. Is, a huge upstream preventative measure. And, not only does it reduce overall cost, of course, to both the patient and the system, but have better health outcomes. Next slide, please. So I'm just going to walk through, some of the examples that, we've already talked about, and just through more of a vaccine access lens. So, of course, as I already mentioned, access to internet, so many vaccine appointments were related, you had to have the ability to go online, find when the next appointment was, and sign up. Your level of housing, you can keep going, Laura, thanks. Built environment, right? Rural areas, you may have to drive an hour or more to access a vaccine. Not having affordable transportation, and then another piece that we haven't quite touched on yet is immigration status. So, those who are undocumented may have been afraid to go to a CVS and, ask for a vaccine. They may have thought they needed to show proof of citizenship. They may not have had insurance coverage, and thinking that was another barrier. And then, of course, there's the medical mistrust about maybe the vaccines themselves, but also concerns about the actual appointment to get the vaccine. So next slide, please. So this is an article I found, one of few that I was able to, find that really touched specifically on barriers to COVID-19 vaccination. And you can see that social determinants of health, are front and center here. I think other, factors, of course, is work and caregiving responsibilities. As Laura had mentioned, if you don't have paid time off in order to, get the vaccine, or you're just not able to, step away from your caregiving responsibilities, that's another factor. And then there's, concerns about underrepresentation of minorities in the vaccine clinical trials, and, other things, of course, that we've already talked about. I think, a key thing that, really came out, I think, after the first round of COVID-19 vaccinations was that a lot of people didn't feel comfortable with the max vaccination sites. They were outside of their local community and had trouble getting there. They much would have, preferred having it at their local community center, for example. And so I think that, is one lesson learned from that first round as another example. Next slide, please. So, a lot of things have already been happening and continue to happen, which is great, as, strategies and possible solutions. So, for example, trying mobile vaccination clinics. And then, for a long time, of course, home health agencies have providing in-home vaccination appointments. And, a lot of senior centers can also do that. And, looking at, who, where do people go? Who's trusted for them in terms of whether it's their faith-based organization or maybe it's their local barbershop, as sources of information that they can trust. And, for another example is, some cultural centers. So for the Latino population, there was a great overview of a cultural center in a city in Texas that was a, leader really for the Latino population in terms of providing vaccines themselves, as well as vaccine information in their own language. And, that was a trusted place for the community to go and how important that is. And then, of course, partnering between, it could be that an area agency on aging partners with their local, public health council around, making sure people know where the vaccines are, how to access, helping them access by, meeting those other needs that we talked about, transportation, supporting with, food insecurity, housing, and other support so that, people do have the, capacity to seek out vaccinations. Next slide, please. So here's a case example from an area agency on aging in Maine, and they were right on the front lines. This was really during the earlier days of COVID vaccines, but I really think area agencies on aging have continued to be, a crucial piece of really helping people, especially those who are isolated and homebound, helping with scheduling. Again, maybe they don't have access to internet, supporting them through that process, arranging for transportation, and then again, the key of having those partnerships that are in the local community. Next slide, please. This is just a nice summary of what we've been talking about today. I think it's really meeting people where they're at, really focusing in on the local environment, partnering with, trusted cultural centers, community centers to be the messengers, promoting, again, the community-based piece, being consistent and accurate. We all know there's been so much misinformation out there, and I really think that's, it's key to have the right information getting to the right people, and then of course the culturally and linguistically appropriate piece. Next slide, please. So this is just another example from Maryland. They had this great, Booster campaign. I think again, misinformation, right? A lot of people thought they couldn't get the booster and the flu at the same time, which you can. It is safe to do that. And then also in this case, they offered it in multiple languages, which is great. And so that's a really good segue over to a series that we're going to be starting soon. So I'm going to hand it back to Laura to talk about our class series.
Thank you, Laura. Yeah, so we've talked about the fact that having culturally and linguistically appropriate services for our patients really help to ensure that they get equitable care. So we will be starting a series talking about culturally and linguistically appropriate services based on the HHS national class standards. So we have an assessment that we're encouraging all of our facilities to take, and this is the link here at the bottom where it says IPRO Assessment of Cultural and Linguistic Services. It's an online assessment, and it really helps you to learn where your organization is in implementing class services. And then we will be doing an educational series going through each of the standards from the HHS national class standards. So I just wanted to bring that to your attention. You're welcome to go and take that assessment, and then we will provide a report to you so that you can see where there are opportunities for improvement in implementing class. So just to switch back to immunizations, we have highlighted here some of the great resources that we've put together. Some of these are for actual patients, some of them are for the providers. So these are just screenshots of 3 of those particular resources, and where you can find them are in the IPRO resource library. And we have a link here. It's called Worth a Shot, and that'll take you to many of the resources we have around immunizations. Some of the other topics that we discussed today, Vital Talk, social determinants of health. If you're just getting started on addressing social determinants of health, we have a great Getting Started guide. We have a link here to the CDC vaccine equity information, the Surgeon General's misinformation toolkit, And also the CMS Office of Minority Health has Medicare information in 18 languages. So that's a great for, those are great resources for providing culturally and linguistically appropriate services to patients. And then the last resource is the CDC Health Equity Guide, Guiding Principles for Inclusive Communication. And that's particularly helpful, again, for cultural and linguistically appropriate services. Just some articles that you might find of interest around this topic. And I'm now going to turn it back to Mary Ellen for managing the chat.
Thanks, Laura. And Laura, that was a great presentation. So I would encourage anyone who has questions to put them in the chat box. If you would like to come off mute and ask your question in person, that would be great as well. And while we're waiting for that, I just had a question of my own. You know, looking at all these social determinants and the disparities, you know, I often think of patients that I've had when I was a home care nurse years and years ago, and you talk about social isolation, and it's certainly worth a conversation about how to partner with folks to really find these folks and figure out their needs. But when you don't know that they're out there, any thoughts on ideas or just some of the challenges associated with, we know that there are folks socially isolated out there, but how do you target them when you don't know, exactly the numbers? I'd be interested in your thoughts on that.
Yeah, thanks, Mary Ellen. I think that's a really good point. You know, I think, when I was at an area agency on aging, it was always like, know us before you need us. How do you get the word out there? I think one of the top frustrations of folks is where do you go for information? And I think if you don't have internet nowadays, you're even more isolated. So I think that's where, maybe, the opportunity is if they, are in a doctor's office for a visit, having that social determinants of health screening, doing a screening for social isolation. And we actually have a great resource on that, sort of start that conversation, see where the patient is at in terms of, they are living alone, or, even if they're not living alone, but they're still feeling isolated, because, loneliness and isolation are actually, not the same thing. And so, maybe that's an opportunity, or, hopefully they're, intersecting, perhaps in at like a local senior center, and maybe there's an opportunity through there as well. But, often it is, the healthcare world where, they may discover what's going on, and then that's an opportunity to share resources and services that are available.
I would agree. Thanks, Laura, for that answer. And I, thinking about it while you were discussing some solutions, I can recall even partnering with your local fire departments, because oftentimes they get calls to check on the well-being. And of course, that could open a whole Pandora's box. But police and fire services, I feel sometimes we forget about them, and they are in the community touch points a lot. So I sometimes think they work as, co-social workers, if you will, because often their job isn't fire or medical related, but they come into a social environmental nightmare. So.
Right. And I think, a lot of times referrals come through adult protective services because, a call, the police or EMS or fire went out and they saw, a lot of concerns, or maybe the elder especially, ended up in the ED. And so then, adult protective services is called, and then they can see, what are the top needs here and how can we help address that? So that happens a lot.
Excellent. So if anybody has any questions, I don't see anything in the chat, but feel free to come off mute to ask a question or type in chat if you're shy. While that's happening, Laura B., if you could advance the slides, we'll just share with folks our upcoming series. We hope you share this series with folks that you think might be interested. I think one more, there we go. And we are recording this, so we will be posting our session and the recording in a few weeks. and I will let registrants know when that's up and available. This series continues through February 1st, every Wednesday at noontime. Our next session is next week, January 18th. We'll talk about vaccine myths, misinformation, and fatigue. I'm sure a topic maybe people are even tired of, but we have a guest speaker, Dr. Elizabeth Talbot from New Hampshire, who is a practicing physician, but also an ID specialist. So we're excited to have her share her thoughts on the COVID-19 vaccine booster and all the challenges associated with it. The week after, motivational interviewing with our own Margie McLaughlin. And February 1st, we'll talk about immunization's role in chronic disease management. And I think that's an important piece to, if you look at the It's Worth a Shot webpage, we have a campaign going on where we're featuring what we call the wave. What about vaccine every time? So the idea is that, together, if we are redundant in our messaging at any touch point for patients, residents, consumers, that eventually will wear them down. So immunization's role is part of your medication management, your fifth vital sign, if you will, and just really pushing that message as much as we possibly can. Any last thoughts or questions before we finish up? Thank you all for participating. We're so glad to see the registration numbers have really increased this week, so we're happy to have you participate. Please pass this on. We're happy to continue this partnership and hope that these sessions will be useful. Have a great afternoon. Thanks again, Laura and Laura.